cardiovascular, neurological, and respiratory effects, as we'll be seeing further. Now, prevention of these sympathetic responses is essential for smooth induction, especially in patients who are at high risk, such as patients who are hypertensive, patients who have myocardial infarction, and in patients with raised intracranial pressure. So, in a nutshell, stress response to laryngoscopy can be described as an elevation of heart rate, blood pressure, and intracranial pressure. And this is associated with the act of laryngoscopy and intubation in patients with the risk factors. So what are the risk factors to having these features that we just mentioned? The first is laryngoscopy and intubation in light planes of anesthesia. We've always known that when you are using inhalational agents, the endpoint for inhalational induction is actually the stage 3 plane 3 of Guedel's staging of anesthesia. And also, if we are using our intravenous induction agents, this patient may have attained adequate depth of anesthesia before intubation, before laryngoscopy and intubation. Now, if there's a prolonged time for laryngoscopy and intubation, there's also an increased tendency for this pressure response to occur. Now, the elevation of vagally innervated posterior part of the epiglottis by the straight Miller's blade, of which we'll be seeing later in this presentation, that the use of the Miller's blade or the straight blade is associated with a higher pressure response to laryngoscopy as against the use of McCoy laryngoscopes. Now, when there's a greater force used to displace the tongue, this also has a higher propensity of pressure response to laryngoscopy. Now, the more the degree of the manipulations or an attempts at laryngoscopy and intubation, the higher the degree of this stress response to laryngoscopy. So this is just a brief anatomy of the upper and the lower airway. The upper airway comprising of the nasal cavity, the pharynx, and the larynx, and the lower airway comprising of the trachea, the primary bronchi, and the lungs. So also a very relevant anatomy of the tongue is also important. The tongue, and particularly I'll be talking about the sensory innervation. The anterior two-thirds of the tongue is supplied by the mandibular branch of the trigeminal nerve. And the posterior one-third of the tongue is supplied by the glossopharyngeal nerve, of which is important in our discussion today, as we'll be seeing going forward. Now, for the relevant anatomy of the larynx, the sensory supply of the larynx is of importance here. As we all know, the above the vocal cords and below the vocal cords. So above the vocal cords, the sensory supply, and it's important to know that the vagus nerve supplies the sensory supply to the larynx. Above the vocal cords, the supply is via the internal branch of the supralaryngeal. And below the vocal cords, the supply is via the recurrent laryngeal nerve. The vocal cord itself is supplied both by the supralaryngeal nerve and the recurrent laryngeal nerve. And like I said, the inputs will be known as we proceed in our discourse. So the physiology of the laryngeal response. The physiological and pathophysiological basis of the phenomenon, as well as the best methods of controlling it, are not fully elucidated. However, it is known to be a reflex sympathetic and sympathoadrenal response that is provoked by stimulation of the nasopharynx and the pharynx, and the largest reflex increase in blood pressure being evoked from the nasopharyngeal region and the smallest from the tracheobronchial tree. The reason being that the nasopharyngeal region is where the impact more, the force of the laryngoscope impacts more during the process of laryngoscopy. So this is just a pictorial representation of the autonomic pathway. It comprises of an efferent, and then the brainstem, which these impulses go, and the efferents, which send back the effects that will show us the elevated heart rate and blood pressure. So the afferent innervation, the nasopharynx, the maxillary branch of the trigeminal nerve. Then for the pharynx and posterior third of the tongue, the glossopharyngeal nerve is the sensory innervation, which is the efferent. And for the larynx, the superior laryngeal nerve and recurrent laryngeal nerve are the efferents that are very important. The autonomic pathway, and this is just a repetition and a diagram that is showing, this is just the diagram that is showing the autonomic pathway, particularly the efferent to this reflex. So like I said, while the afferent limb of the reflex arc is via the cranial nerve and the upper airway, the efferent is via the sympathetic nerve. However, the central integrating station is not satisfactorily described in literature. So the reflex could originate in the tracheobronchial tree or larynx and effect a response by sudden increase in vagal tone by the glossopharyngeal and vagal afferents to the brainstem. The vagus is sensory nerve to the root of the tongue, epiglottis, and trachea, and this forms the afferent arm of the reflex. The brainstem in turn causes a widespread autonomic activation through the sympathetic and the parasympathetic nerves. It must be noted that bradycardia, often in neonates and infants, is the autonomic equivalent of the laryngoscopic response because of the poorly developed sympathetic system. So the parasympathetic is actually predominates in the neonatal and infant age group. So stimulation of the synuclein node results in bradycardia. And as we'll be seeing, this stimulation, its effects on the airway will give, that's particularly the glottic opening, will give rise to reflex closure of the glottis, which would present as a laryngospasm in these infants and neonates. Now, in adults and adolescents, the common response to airway manipulation is hypertension and tachycardia, which is mediated by the cardioausculatory fibers, that's the cardioausculatory nerves, that the T1 to T4, and the sympathetic ganglia. This response includes widespread release of norepinephrine from the adrenergic terminals and epinephrine from adrenal medulla. It is about to know that in addition to the activation of the autonomic nervous system, there is stimulation of the central nervous system, as evidenced by an increase in the electroencephalogram activity and also cerebral metabolic rate and cerebral blood flow. This in turn increases the intracranial pressure and worsens in patients who are at risk of, who already have a raised intracranial pressure. This increases the likelihood of phoning in this set of patients. In patients with compromised intracranial compliance, like I mentioned, the increased cerebral blood flow may result in elevated intracranial pressure, which in turn may result in herniation of the brain contents and severe neurologic compromise. So this is just a diagram that is trying to explain the autonomic pathway, like I had earlier mentioned. The sympathetic chain ganglia, that is particularly the efferents, that's the non-epinephrine release at the adrenergic nerve terminals, as well as the renin release from the juxtaglomerular apparatus. Now, all this will result in an vasoconstriction and an elevated blood pressure and heart rate. The vagal efferents to the glottic will result in the laryngospasm, especially in the infant and the neonatal group. And the vagal parasympathetic to the sinoatrial node will result in bradycardia, which is mostly seen in children. This is just a similar implementation of what I'm just trying to say. And this is just still the autonomic pathway. Like I had to project this slide to maybe if one of the images would benefit you more than the other, we can go ahead to give a better explanation. So what are the complications of stress response to laryngoscopy? Now, in patients but in the cardiovascular system, when there's an imbalance between oxygen supply and oxygen demand by the heart as a result of increased myocardial activity, this may give rise to a myocardial infarction. Now, in patients in the central nervous system, patients who have in the central nervous system, because of the increased blood flow in patients who already may have a compromise in the blood-brain barrier, a raised intracranial pressure may be serious in this set of patients. Then in ophthalmic patients, because of increased blood flow, increased blood flow to the eye, this may give rise to a raised intraocular pressure. Therefore, in patients who have glaucoma, attenuating pressure response to laryngoscopy is actually a must. That in metabolic conditions, such as thyroid disorders and pheochromocytoma, elevated blood pressure, the pressure response to laryngoscopy may be deleterious in this set of patients. So obtaining pressure response to laryngoscopy is very essential in this category of patients. Now, this was a study that was done to actually ascertain the various agents, pharmacologic agents that are used to actually obtain pressure response to laryngoscopy. And in this study, the drugs that were used were fentanyl, lidocaine, diltiazem, nitroglycerin, esmolol, and dexmedetomidine. So the parameters that were used were the mean arterial pressure, the random blood glucose, cortisol, and the serum amylase levels. So it was found that the times were before induction, after induction, and 5 minutes after intubation. And because we expect that within 30 seconds to 1 minute of the laryngoscopy, that is when the pressure response is maximum. And at about 5 to 10 minutes, there's a decrease in the parameter, heart rate and the blood pressure, as the case may be. So it was found that at the end of this study, it was found that the efficacy, it was found that the parameters, that's the mean natural blood pressure, the random blood sugar, the serum cortisol, and the serum alpha amylase were significantly lower in patients who were administered dexmedetomidine and esmolol compared to the other drugs that were administered. So the goal of pressure response of the goal of obtaining pressure response to laryngoscopy is actually to limit the effects for hemodynamic stability. Particularly, it is important in patients with cardiovascular disease and also raised intracranial pressure, as well as intracranial arteriovenous malformation. This reduces the risk of myocardial ischemia, arrhythmias, and aneurysm rupture. So how do we attenuate this response to laryngoscopy? Various strategies have been developed for this purpose, and we broadly classify them as the non-pharmacological, the pharmacological, and nerve blocks. So the pharmacologic options are the deep, ensuring that this patient, the deep anesthesia before onset of laryngoscopy and intubation, opioids, lidocaine, use of beta blockers, and calcium channel blockers. So the first group of drugs we'll be talking about are the opioids. The opioids are they block the central mechanism, that's of the sensory input and integration. Among the opioids administered intravenously, they are all found to attenuate the pressure response to laryngoscopy and intubation. Fentanyl is administered intravenously at a dose of 2.5 to 5 microgram per kg. So fentanyl is administered at a dose of 0.5 to 1 microgram per kg. And alfentanil is administered at a dose of 5 micrograms per kg. It is said that among the intravenous agents, the fentanyl comparably attenuates intubation response. However, from the study, like I highlighted before, this about 5 slides back, that study showed that dexmedetomidine was actually preferable because of the favorable responses in terms of the mean arterial pressure and as well the serum amylase level, the random blood glucose, and the cortisol level. It was shown that they actually have the best effects to attenuate pressure response to laryngoscopy. Also, alpha-2 agonists are also a class of drugs. Like I said, they act to block the central mechanism, And examples here are the dexmedetomidine, which is administered at the bolus of 0.5 to 1 microgram per kg intravenously over 10 to 20 minutes prior to intubation. Clonidine is administered at a dose of 2 microgram per kg over a 10 minutes period. Also, gabapentin and pregabalin administered orally, and gabapentin at a dose of 900 milligrams orally, pregabalin at a dose of 150 milligrams orally at about 90 minutes prior to surgery. They help to attenuate the hemodynamic response to intubation. Then there are also a group of drugs that block the afferent pathway. So these drugs, in blocking the afferent pathway, we can actually do a nerve block or topicalization of the airway. And particularly here, the superior laryngeal nerve block can be done either using the landmark technique or under ultrasound guidance. Then topicalization of the airway using local anesthetic, either by nebulization of 5 ml of 2% lidocaine or using 4% lidocaine spray is also very important. Then for blocking the efferent pathways, the beta blockers, which is the use of esmolol at the dose of 1 milligram per kg about 3 minutes before intubation is important. Calcium channel blockers, particularly nicardipine at a dose of 30 milligrams per kg, micrograms per kg, or verapamil at a dose of 100 micrograms per kg, given 30 minutes prior to intubation. IV lidocaine 1.5 milligrams per kg over 10 minutes is also known to block the efferent pathways. Then other ways to reduce this response include deepening of our inhalational anesthetic agents, administration of magnesium sulfate at a dose of 30 milligrams per kg in 100 ml of normal saline, as infusion of 15 minutes for laryngoscopy and intubation. Then second dose propofol and STP, also very important. Then I just an article on the review of hemodynamic response, the use of different types of laryngoscope blades. I also came across it during the preparation of this presentation. And in this article, it was actually found that the use of Macintosh blade and Miller blade increases the pressure response to laryngoscopy. However, the use of the McCoy blades during laryngoscopy had a tendency to the pressure response was reduced with the use of the McCoy as compared to the Macintosh and the Miller's blade. Now, the recent trends, in the recent trend, the use of the nebulized lidocaine, clonidine, and dexmedetomidine has been advocated as a method of reducing the pressure response to laryngoscopy, particularly the afferent pathway, because it's actually particularly the glossopharyngeal nerve in the tongue, as well as the internal division of the superior laryngeal nerve are actually blunted, and this will in turn reduce the tendency to have an exaggerated pressure response to laryngoscopy. In conclusion, pressure response to laryngoscopy is a common manifestation during laryngoscopy and endotracheal intubation. Although it may not have adverse effects in healthy patients, it is important that the anesthesiologist should have a high index of suspicion if it's risk factor, as well as patients where it can result in deleterious effects, and also be able to manage it as it and when due. Thank you very much.
Thank you very much, Dr. Chitindi, for your presentation. Dr. Chitindi, it discussed the stress response to laryngoscopy.
We can't hear you, Dr. Gray.
Can you hear me? Hello? Hello, can you hear me, please?
Yes.
Oh, okay. Thank you very much. Thank you, Dr. Chitindi, for your presentation on the stress response to laryngoscopy. He introduced the topic, he gave us the relevant anatomy, and the physiology of stress response, and the risk factors and different methods of attenuating them. We talk about the alpha-2 and some regional blocks. Some current concepts in the management of in attenuating pressure response to laryngoscopy. So right now, we would like to entertain comments and questions and contributions. You can type your comments in the chat box, or you can comment by unmuting yourself. Okay, there's a question for you, Dr. Shitindi. It said, you mentioned the laryngoscopy response in neonates and infants. How do we prevent or attenuate this response in them?
Thank you very much for the question. So in infants, most times in infants and neonates, what we do for them is actually inhalational induction. So in inhalational induction, using in as much as using inhalational induction, there's no clear point for there's no clear endpoint for laryngoscopy and intubation. We ought to achieve the features that we feel this child may be deep enough to actually perform laryngoscopy intubation, such as global hypotonia, centrally placed pupils, as well as shallow breathing. Now, if this child have these features, I think this child is deep enough for laryngoscopy and intubation. So the second question in the chat box said, what was precedent and ESMO law compared to? So the ESMO law was compared to fentanyl, dexmedetomidine, as well as fentanyl, dexmedetomidine, and clonidine. Those were the drugs that were compared to ESMO law. So the findings in this study actually show that ESMO law and dexmedetomidine were the drugs that were most favorable to obtaining pressure response to laryngoscopy and intubation. So those are the drugs that were compared to ESMO.
Okay, thank you, Dr. Shitindi. There's another question here. It says, is there a role of anticholinergic, tropine, cycloparylene in attenuating this response?
Thank you very much for that question. From my materials I saw for this topic, I didn't see the role of anticholinergics, atropine or glycopyrrolate in attenuating this response. I didn't see any information. Thank you.
Dr. Shitindi, we can't hear you. There's a mic. Speak into the mic of your system.
Okay. The question was the role of anticholinergics in pressure response to laryngoscopy. So I didn't see any information about the role of anticholinergics to obtaining pressure response. However, I would check it up. I didn't see the literature I prepared for this. So the next question I saw was that.
Okay, the next question from Mr. Adam says, he said, very good presentation. Does magnesium sulfate have any role in suppressing pressure response to laryngoscopy and intubation?
Yes, magniosulfate actually has a suppressing pressure response, laryngoscopy, and intubation. I had mentioned it. So the dosage for magniosulfate in obtaining pressure response laryngoscopy is 30 milligrams per kg in 100 ml of normal saline as an infusion 15 minutes before laryngoscopy and intubation. So it actually has a role in obtaining pressure response and to laryngoscopy and intubation. Thank you.
All right. Some people, we have some hands, some people want to ask questions. So you can, Dr. Michael.
Okay,
Please,
one
you
of
can
our chiefs is
ask your
here. I think that's Dr. Prof. Sir, Prof. Shinaike. Please, sir, if you want to say
Professor
something, just unmute.
Shinaike,
We'll be happy to hear you, sir.
Okay, afternoon. Can you hear me?
Yes, sir, loud and clear. Thank you so much, sir, for joining in.
Yeah, that's fine. Thank you. Now, thank you, the presenter, Dr. Shitinde. Just want to make some corrections about your presentation and also want to make one comment. Now, when you quote anything in your presentation, you should give a reference. Where did you get that information from? You are talking about an article on the different types of laryngoscope. No information about the year, about the journal, about where you got it from. To make it worse, at the end of your presentation, there is no slide on references. No, that's not good enough. For any scientific presentation, you should let us know where you got your information from, okay? I mean, there's no doubt you've actually tried to project the topic. And I think this is one area that I tell my residents to actually go and read and study very well. Most of them don't know all this. So it's a good opportunity and I can see most of them join, a good opportunity for them to know what this is all about. Then finally, did you come across the duration of laryngoscopy and intubation as a factor in the level of blood pressure or sympathetic response that you get, the duration of laryngoscopy and intubation? Did you come across that?
Yes, I actually did, sir.
So what is the best time you should spend when you are intubating? There is a cutoff.
Okay, sir. The best time should be within 30 seconds. Because after 30 seconds, it is set
Within,
by,
sorry? Within
30 seconds. Within 30 seconds, sir.
I think that's long. Do you have a reference for that?
Yeah, yes, sir. The article I actually saw, the article I came across.
Okay.
The article I came across actually gave the reference within 30 seconds. That is when, if it's beyond 30 seconds, that is when there's an exaggerated response to laryngoscopy and intubation. I'm so sorry that I
think the goal is actually to make it. The goal is to make it less than 15 seconds. That's the goal. So when you are intubating a patient, if you can do it in 15 seconds, is the best. Is the best. Okay. So yes, sir. I think I will stop there. Thank you very much. Bye.
Thank you very much, sir. Thank you very much, sir.
Thank you so much, Prof. Sir, for joining. I think we have another hand up. Dr. Michael.
Yeah, good day, everybody. Thank you, Dr. John, and the moderator. I just don't know whether I should talk after my teacher, Professor Shinaike, has spoken already. So I was a bit whether I should put my hand down, but I couldn't. Yeah, so the presenter, thank you for the presentation. If I had your contact, I would have sent you 2 articles from the University of Lagos on hemodynamic responses to laryngoscopy and intubation. I'm sure by a team of doctors there, Dr. Adekoya, Professor Desalu, and a group, so that you can get the timing and duration quite, and you can reference it. Maybe I'll talk to Dr. John if I get, so that I can send you those articles. These are articles that have been presented, and it's in which if you make reference to them, you can actually form the basis for whatever such is this kind of gathering. So I don't make high presentation without references. Yes, back to this. I actually was interested in, I thought we were going to looking at intubation versus use of LMA vis-a-vis hemodynamic responses. Then I also was looking at maybe when you're looking at the risk factors affecting pressor responses, where you're looking at straight blade like Miller's versus McIntosh versus McCoy, though you didn't make reference to them and you said McCoy was shown to. Yeah, I wanted to trace us back a bit that in the development of Miller's straight blade, how it works, it goes straight and lifts the epiglottis directly, allowing for visualization. But it comes with the setback of having the high chance of touching the posterior part of the epiglottis that could trigger those responses as you've explained, because the posterior part of the epiglottis is well innervated by the parasympathetic nerves, the glossopharyngeal vagus, like you've rightly said. But then within that period, there was development of the McIntosh, and there was a lot of celebration when McIntosh came in because of the shape. It follows the shape of the tongue, but the main thing about the McIntosh is the indirect ability to lift up the epiglottis. In which case, when you follow the shape of the tongue, lifting the tongue, because the base of the tongue is where epiglottis has attachment. So lifting the tongue will indirectly lift the epiglottis, which helps reduce stimulation of the vagal responses that will cause that the reflex sympathetic response that will eventually lead to increase in pressor response. So in essence, I was thinking you're going to look at those blades one by one instead of just mentioning the article. I mean, you didn't mention the article that said it, but it's okay. Then in terms of video laryngoscopy, I was expecting that I would see video laryngoscopy vis-a-vis the risk factors you've mentioned, that's blades and the force of lifting the tongue can increase response. So leading to the development or the advantage of video laryngoscopy that reduces this force of lifting, and two, helping reducing the ability to get to the posterior part of the tongue. So such that the video laryngoscopy, apart from the fact that it increases the chances of, improves the chances of first attempt success, also helps to reduce this pressor response. I was thinking I was going to see it, but these are information I just needed us to add to what you have. Then those two slides, I just want us to know that when you look at pressor response, that our teachers from the University of Lagos have 2 or more articles comparing them, and then finally the conclusion is that the use of LMA, if you have surgeries that are amenable to LMA and intubation, and if you can use LMA, use it, because they found out that the response, this laryngoscopic response with the use of LMA for surgeries that are amenable is much, much, much more reduced compared to outright endotracheal intubation. So this is where I'd like to stop. I just wanted to add as an addendum to what we presented. Thank you very much for the opportunity to speak.
Thank you so much, Chief. Thank you so much. I've also sent you a message because we would definitely like the articles for further reading, even on our residence groups. So thank you so much, sir.
Thank you very much, professors and senior colleagues, for enlightening us more on this topic. I want to know, in the absence of any other question or comment, I'd like to hand us over to the NSA, the representative of the NSA, to take over from here. Thank you very much.
Okay. Okay, thank you everyone for coming on. Let me especially introduce our chief, Dr. Queenette Kalu. I think she's still here. The NSA president-elect and the head of the education committee. And like I said, the education committee is the NSA committee that has given us this resident academic series. So we are very grateful to her, and I'm sure she has a few words for us. Chief Ma.
Thank you very much, Dr. Afam, for so effectively coordinating this. And I want to congratulate both the speaker and the moderator for a job very well done. The purpose of the residents webinar is just what we have seen, that you assert yourself and you receive constructive criticisms with which you will go back and redo your slides, which we will share the corrected slides with everybody. I want to thank you for taking the time to research into this and to give us such a wonderful time academic feast. Thank you very much to the presenter. There's evidence of a lot of work put into this, and I deeply appreciate. I want to encourage all the residents that not just for this presentation, but even when you present in your departments, listen to constructive criticisms. What I tell my residents is, as you're presenting, get somebody that is sitting down to take note of the corrections that are being made, so that when you finish, you use those corrections and redo your slides, you'll find out that you will be better off for it. And each time or at any time you're given that presentation to do again, you will see that you will do an excellent job. And should you find it in exam, you can consider yourself as having done excellently well in that particular question. So once again, I want to thank you very much. I also want to thank everybody who has joined. I want to thank Professor Shinaike for not only joining, but for also sharing his experiences, and for everybody who read up the topic and came up with some observations and then contributed ideas to make us richer. I want to say thank you very much. And each time you come to these webinars, I expect that you will revise what you already know, and you will also learn new things. And that is not just for the residents, but for everybody who joins. There's always something to learn. In thanking everybody, I want to recognize, apart from our colleagues, all the consultants who joined. I don't know everybody, but I think Dr. Mwachuku and a few other consultants who joined. I want to especially thank you. I've already thanked Professor Oshinaike. I might have missed a few. I also observed one of our colleagues, Dr. Prosper from, was that Malawi or Tanzania? I think Tanzania, who joined us. I want to appreciate you very much. We are always happy to have our colleagues from around the world joining us, because anesthesia is one big family. Next week, 25th March 2025, we'll have the general NSA webinar, and the topic is safety checklist, learning from aviation cockpit drill for safe anesthesia. We are going to have an aviation expert who is also a medical doctor and a tutor in aviation school talk to us on this very important topic. You will not like to miss it. So kindly spread the message around the country and around the world so that people can join and learn for the safety of our patients. Anesthetists are airway managers. And gradually we are seeing that indirect laryngoscopy, that is video laryngoscopy, is fast taking over from direct laryngoscopy. And I believe that we should look into the stress response associated with video laryngoscopy. And I hope that we can see a lot of research being done in this regard going forward. Lastly, I want to remind all of us that the NSA depends on your dues to keep afloat. We have obligations to the W contribute to session. Once again, thank you very much.
Okay. Well, she had finished speaking, but I think she has gone off. So thank you all very much. We've heard from the president-elect. We'll meet same time Same station. Okay, not the same station, because that's the general NSA meeting, not just for residents, but same time next week. Have a lovely evening, everyone, and thank you all for joining in. Bye-bye.